Chitra ma'am.
Shall now go on to our next speaker, Dr. Abhishek Anand, Assistant Professor, RIO IGMS, Patna, to talk on double trouble, simultaneous management of iris and lenticular trauma. So let's hear from you, Dr. Abhishek.
Good evening, everyone. On the outside, I would like to thank Chitra ma'am and Srinivas sir for giving me this opportunity. Are my slides visible?
Yeah. Yes.
Okay. So I would be addressing through various videos on the one of the very common pathology that encounters our clinical practice, and somehow I feel that it is somehow is not well addressed, and also it's very important for our PGs because they are one of the first persons to encounter who handle these cases. So suture repair is regarding iris tissue defect. Suture repair is preferred to the use of an iris prosthesis whenever possible, and when we are addressing to do the iris repair, we have to create and maintain a pupil size to alleviate the symptoms. However, it also allows the adequate visualization of the fundus. And when you are using any iris devices, we have to take a detailed informed consent and observation of regulatory particular for that country. Now, regarding this, I think on these two techniques, the Siptous sliding knot and the single pass 4-throw pupilloplasty can address almost 80 to 90% of our, and we are very difficult. Now, in our regular practice, we have regularly encountered such cases in which there is a traumatic subluxation of the lens, and we have to do a pars-plana vitrectomy and SFIL. And after completing the SFIL, what we notice here in this case that even after doing giving a pilocarpine injection, we have a pupillary diaphragm which is almost 8 to 9 millimeter, which will not elevate the symptoms of the patient or will lead to any visual benefit. And a simple 4-throw pupilloplasty, a 2 anchoring technique, one in the superior and the inferior, will almost decrease this pupillary aperture to almost 4 to 5 mm. Now, what we notice is that when we do a 2-point stitching, is that the pupillary aperture is almost ellipsoid in shape, and there are 2 slits that are left, but it is way better than 8 to 9 mm. This is a patient which was sent to me by one of my FECO colleagues, and he had done a very wonderful phacoemulsification, but then the patient was complaining of uncontrolled blinding due to light and with very less contrast sensitivity. And in this, after doing looking for what is the yield of the tissue, iris tissue, we could see that it's still a 7 to 8 mm of the pupillary aperture, and again simple 2-point anchorage, and we achieve almost 3 to 4 mm of pupillary aperture. However, ideally, the ideal situation would be when we do a continuous 360-degree insect large of this. So this is one of my very early videos around 8 to 9 years old, in which I tried a 360-degree pupillary. Not a very wonderful surgical video, but then I think it has been mastered by a few surgeons worldwide, and in which we do a 360-degree insect large. What we noticed is that what I learned when I retrospectively analyzed that in this video, I'm trying to, the needle end is trying to grasp the tissue of the iris tissue, but what it has to be other way. The needle has to be stable, and you have to grasp the free tissue, and you have to take big bites on the needle. So the needle has to be stable, and you keep passing this, and then you can give a good 360 insert large. And another use of this Siptous sliding knot technique can be in the inferior tissue defects, which we can encounter as a rectus.
1 minute remaining.
When we are doing an inferior iridotomy. And similarly, in the cases of coloboma, where we encounter this situation. But not all tissue repair can be that simple. So this is a case of 270-degree iridodialysis with patient. So in this case, what we did was we did a 360-degree periotomy, and around 2 mm behind the limbus, we did a Hoffman pocket around the parallel to the area of iridodialysis. And we used the iris retractors to restore the normal anatomy of the iris. And once we have restrained the use of by using 4 iris retractors, we have attained the configuration of the iris. We proceed with the lens aspiration and implantation of a PMMA lens, and we use the swing machine technique by Dr. Ravi Kumar, who has very wonderfully elucidated that if you pass multiple rows of the 10-oproline threaded in the 26 gauge needle, and then you cut the adjacent edges, and then you throw it. So, then you sew it the adjacent edges. Then you can very well anchor the sutures, anchor the iris to this, and in this we can achieve a significant amount of anchorage. we were, a bit overboard that we could do. You could do a pupilloplasty also, like the sepsis through a sepsis node, but we didn't. We felt that if we try it, these knots will come out. So we just ended, and this was our post-op result. And just to end this talk, I leave it to my learned panelists that this is a case in which we have trauma, and what should be the approach? What should we do? Should we do a pupilloplasty in this case or not? So we see it's a post-traumatic. There's a central scar at the capsule, and we are able to do a good capsulotomy and implant the lens. But at the end, what we see is that we have a pupillary aperture of around 4 to 5 mm of size, and we can see the IOL rim, and we have 3 small iridodialysis. So will we proceed for pupilloplasty in this case or not? For the takeaway point, I think every PGs must have to focus on the pupillary aperture, and we have to give a good vision to that patient. Thank you.
Thank you very much, Doctor. Shall we have Dr. Dr. Karobi to discuss this?
Yeah, thank you, Chitra and Srinivas. Lovely array of cases, Abhishek, and a surgery well done. There is a definite learning curve to any kind of iris repair, though he seemed to do it very seamlessly and easily. To the PGs, it looks a very easy procedure, but it does take time. So, like each one, I think the message would be that when you have such a case, you plan in advance what you want to do and the kind of suturing that you want to do, whether it's an iridodialysis, it's a different kind of suturing where you put it through a groove, or you want to do suturing which is a single pass 4th row pupilloplasty, then you know which areas you're going to enter, which areas you're going to pull the knot out from, and how you're going to anchor it, because you have to be very well up with what you're planning to do for your case to have an effective result. And also the thing is that, see, it's important that you don't cut off the iris or you don't leave it as it is, because the tendency sometimes is there to do that, because you are going to alleviate the patient of symptoms like glare, a lot of light sensitivity, transillumination effects. Those things are done away with. So learn how it is to be done. Before any kind of injury cases, array your instruments as to what you would like to do, your method of approach, and how you would like to do it. And after that, you proceed and do the needful. It might not look easy, but as Abhishek told you that in the beginning, you have to feed the iris onto the needle and not advance the needle across it, because which is a very important tip. And this thing, the Sipser's knot, is also something which you have to learn, because many a times you don't have a capsular support if there is a cataract. So you can anchor the IOL, the haptic, as well as the this iris in one suture. So it helps in that way. But overall, a very nice presentation, Abhishek. Congratulations.
Thank you, Dr. Karobi. Anybody else from the expert panel have anything to add before we go on to our next speaker? Srinivas?
Yes, madam. We can go with the next. Thank you, Dr. Abhishek. A wonderful case. Thank you very much.
Wonderful.